For Aboriginal and Torres Strait Islander children, the 0 to 5s, it's a particularly important time of their life for a variety of reasons. As you know, we have issues with the very early beginnings of life.
Children with acute illness or recurrent acute illness, so respiratory or gastrointestinal infections, ear disease and hearing impairment as a result of that.
A lot of chest infections, ear infections. We get a lot of sores, a lot of failure to thrive, anemia.
Hello, I'm Carla Grant. Aboriginal and Torres Strait Islander people experience some of the worst health problems of any group of people in the world, and these issues start right from the very beginnings of life. Poor health in the first few years of life can really set children back and set in train a lifelong cycle of chronic disease. That's why children's health is so important.
There was a recent Menzies study that showed in children that between, I think, 6 and 30 months, that showed only about 12% of children in that age group had 2 normal ears.
Oh, it might be all right, but this one here's got a hole in it. Let me have a look at this one again.
I think the things for otitis media are the young children, like 0 to 5s, we should be looking in the ears, treating them really aggressively, trying to prevent them develop chronic ear disease.
Many of those infections go on to perforated drums, or the runny ears that kids get. Of course, when they get to school, then preschool or primary school, interferes with their ability to interact and learn, so their educational outcomes and their social skills may be affected, all from things that are by and large quite preventable very early on in life.
In Central Australia, rates of anemia in young children is quite high. Our focus has tended to be, and our guidelines have tended to be, look at children and treat those who are anemic. But I think the way we need to change really is to try to put in programs that will prevent that. So the things that we need to think about are what we do for antenatal women to treat them so that their children are at less risk of being iron deficient.
All finished. Did I put on any antibiotics the other day?
No, I should have had it.
There's issues around skin infestation, say with scabies, which is a big issue, and then the overgrowth of that, and sort of recurrent or chronic skin sores and skin infections, which can then predispose the child to anemia of chronic disease.
But you know what? These are wholly preventable problems.
Treating households, making sure that their environmental health is also looked after in that whole scope of health. Is there appropriate housing? Do they have clean running water? Do they have safe electrical supplies? Do they have refrigeration? How many people are living under the same roof? So there's a lot to it, and I would say they're the main things for any successful child health program. You really can't look at things in isolation.
Good boy.
Because as you know, we don't just think of Aboriginal health as how well or how ill an individual is. It's about the well-being and the prevention of illness in an individual. It's about family health and the extension of that into, the well-being of the community.
There are entire communities banding together to tackle the issues, and they're getting great results. One of the ways that health is being improved is through immunisation against many common childhood illnesses.
Our immunisation rates are actually not bad in Central Australia. They could be improved, and we just have to remain vigilant to make sure that they remain good. I don't see many objectors to immunisation. I think maybe part of that reason is that Aboriginal women, grandmothers can remember children dying of meningitis and some of these vaccine preventable diseases.
Here at NUU we've got the highest rate of immunisation in Australia at 98%, and that's excellent. We know the children, we know the mothers, and they know us and they trust us, and we just let the mothers know that their children are due for immunisation, and they either come in by themselves, or when the immunisation's due we just go out, send a driver out, and they'll just remind them that their kids are due, and you generally bring them in. Give you some more amoxil. and they get done. You've still got that dementia.
In the Northern Territory, the GAA or Growth Assessment Action Teams are a great example of what can be done to help improve the health of Aboriginal kids, and they use a real team approach.
I'm a public health nutritionist. I work in remote areas in the Northern Territory with the remote community people. The main focus of my work is training and supporting Indigenous people in nutrition and child health activities, setting up and supporting programs around child health and nutrition.
I'm an Aboriginal health worker specialising in child health. I look after the 0 to 5s. Sometimes I go pick them up, bring them into the clinic to do weighing and measuring. And if the kids aren't doing well, just talk to the mums and tell them which foods they're supposed to give the little ones.
The key to the success of the Growth Assessment Action Teams is community capacity building. They take a three-pronged approach that involves consistent training of all health staff working in remote areas, putting in safety nets for the kids who aren't growing so well, and formally assessing kids twice a year.
Head circumference equal.
The teams feed this information back to their communities, who then use this to set up initiatives like nutrition programs to build on the assessment.
For sustainability, the focus has really been on training up people like Marion who will be at Hermannsburg for many, many, many years and will see the passing of many non-Indigenous health staff coming into and out of the clinic. And she knows the families and she knows the issues much more than any of us would ever know.
Yeah, we had quite a big difference with the kids, especially the nutrition and iron deficiency, just by, education and telling them what to do and that. It's quite a big difference. For things to work, you need to have, a good partner to work with.
I often think of my training as a dietitian and how little of that I've actually used in this context, and I've learned a lot more from Marion than what she's learnt from me, I can tell you that much.
When you see kids that are sick and the interventions for those kids, when you say to the parents, you should feed your child better or you should do this and that, it's almost blaming the people who shouldn't be blamed for this. Whereas if you can work to build up some strengths within the community, you're putting a solution in rather than blame.
We have to try and get these younger kids and start with them and talking to them about hygiene, washing themselves every day, brushing their teeth. But then, it still goes back to the parents, doesn't it? Because without the parents, you're just not going to get anywhere. It's just a vicious cycle.
It's sort of a bit like the chicken and the egg, because you need healthy families for healthy children, and healthy children grow up to be healthy families. So, where do you intervene? You intervene in both places, I guess. You try to help families to be as healthy as possible, and you try to look after the children and help them get over their acute illnesses so that they are healthy.
In Alice Springs, the Central Australian Aboriginal Congress is a health service that's been around for many years, and they've been doing great stuff with communities in relation to early childhood health. Their results have been startling. The death rate for the 0 to 5 age group has fallen 85%, which is an almost tenfold decline.
All right. Yep. Biggest noise because I've got to see right in the back.
Yep.
Okay, go. Oh my goodness.
One of the biggest changes that's happened in Aboriginal health is the improvement in health status in the 0 to 5 age group. And often we hear people saying, Aboriginal health, nothing's improved. It's actually very wrong. There's been a dramatic improvement in the health status in the 0 to 5 age group in the Northern Territory, and particularly in Alice Springs.
How often does he need the blue puffer?
We service Aboriginal people who live in the town and the town camps, as well as Aboriginal people who live on outstations within a 100-kilometre radius of Alice Springs. That represents around 6,000 resident clients each year who use our service, and around 1,500 to 2,000 visitors. And Congress has been in existence since 1973. So we're seeing the entire child population of Alice Springs every year, plus a lot of visitors. And we're seeing them on average 6-7 times a year each. So they're coming frequently, they're coming often, they're having their weights checked. They're being immunised. We have an immunisation coverage rate of 92.4%, which is above the national benchmark of 90%. We employ our own audiologist, hearing health worker, and children who have any suggestion of hearing difficulties get referred to that program, but importantly, those staff have the special skills to even be able to assess 9-month-old children to see whether there's any sign of hearing loss.
Okay, we'll have to see a doctor about that one.
But there are still some women and babies who are at higher risk than others of falling through the cracks. So Congress has set up a home visitation scheme for this group to make sure they can get good assistance and hopefully head off problems before they occur. These families are enrolled in an under-2s program and are supported by midwives, nurses and health workers who form a long-term relationship with them. They visit the families twice a week and keep an eye on the children until they're 2 years old.
And it takes a very holistic approach. So, of course, the program looks at the growth, the weight of the children, the nutritional status, feeding, immunisation status and all those more medical aspects of what's important in terms of early childhood. But it also looks at the broader social determinants of the social environment. Is there a problem with alcohol? Does the mother have a problem with domestic violence? What's the level of education that the mother's achieved? What employment prospects are there for the mother if the mother needs to work? And importantly, getting the mother linked into social networks like playgroups, childcare centres when that's appropriate, the toy library, the town library. Aboriginal kids are now using the toy library regularly with the support of the program. The evidence base for what we're doing is absolutely rock solid. It will make a difference in 10 or 15 years, and it's something we will keep on the case of.
Before I started the hospital, I worked in remote communities for several years, so I think that's brought with me to the hospital insight into what it's like out bush, what are the difficulties in raising children in remote communities.
Carmel Hatch is the Paediatric Liaison Officer in Alice Springs. She has the important job of linking communities with mainstream health services like the hospital. She sees every Aboriginal child in the Northern Territory. She makes regular contact with remote communities, health staff and other organisations to ensure that when a child leaves hospital, that the care doesn't stop there.
Children would be coming in from very remote communities to a big hospital and then would be returning to remote communities with sometimes not adequate follow-up. So we started a database to ensure that no matter where the child went back to, the child was returned for whatever investigations needed to be done. I have an incredibly computerised brain after being here for over 27 years, so children that are at risk, I tend to be able to remember them very clearly who I have to check on, so I make regular contact with remote communities. Particularly I do a lot of nutritional follow-up with them, so kids are at risk for poor growth, so I talk daily to most of the remote paediatricians. Since the introduction of the outreach liaison positions, follow-up now is fantastic. Children don't necessarily get lost to follow-up. I don't actually have any trouble locating children. I have a great network of Aboriginal friends, and I rely heavily on Aboriginal health workers, Aboriginal organisations to ensure that the kids get the best service we possibly can in considering our remoteness.
8.33.
So we start early. in our services, in visiting maternity, ensuring children go home breastfeeding. We provide intensive in-services to the staff of the hospital, especially the children's ward, because we have a lot of transient staff, so we want them to be really up with what's appropriate for Aboriginal children in remote communities, as there's no free availability of formulas and fresh running water, and it's very, very expensive and it's unnecessary, so we ensure that all staff are very aware of those facts, of the remoteness of where these children come from. It's essential that we always have Aboriginal input. We use the Aboriginal interpreters available at the hospital at all times. Growing up children is different for Aboriginal people to what we think it should be, and it's so important to always have that really open mind, that there's two ways to do everything and mine isn't always the right way. And I think just always listening, taking it very slow, is the best way to go. It's been the most valuable lesson I've ever learned.
Aboriginal kids are getting much better follow-up with the help of paediatric outreach services, but they can still face enormous problems with getting adequate nutrition when they're back home in their communities.
It is actually more than just nutrition or just the food that goes into the mouths of the children. It's also about the extended family situation, environmental safety and environmental health. So where the kids live and whether their housing is appropriate, whether they have refrigeration. And for example, there are fax programs that help mums with their budget. They quarantine an amount of money every payday that is just available through the shop for buying food for the family and for the kids. But if you've got 10, 12 people in the house, you take that home, it's often first in, best dressed, so mum and bub often miss out, for example.
Many
of them have to have everything freighted in or barged in during the wet, and so there are those sorts of barriers to accessibility of good, fresh, affordable food at the best of times. But having said that, a lot of communities are again taking the initiative. They have their own little co-op set up, they have refrigeration services, they have deals with some of the larger distributors or the supermarket chains or whatever that can provide them all year round with good fresh fruit and veg at a reasonably affordable price. So it's not all spam and white bread.
Nutrition is really important both for children's current health and also for their long-term, health into adult life. The fact that poor nutrition early in life may lead to risk of disease later on. Also the fact that if you can help a young child to start eating a good healthy diet, they'll probably continue eating the similar sort of diet as they get older.
Up on Bathurst Island, an award-winning childcare centre has been set up for the local children and their families. Janani Childcare Centre is the first of its kind. They not only provide long day care and after-school care for an additional 55 kids, but also incorporate a family nutrition program. Throughout all their programs, the overall focus is on nutrition. Back in 1999, when they first started, the Tiwi Islands were known as having the worst health in Australia.
So our main focus has been making sure the children that are here eat well. So we've got a very strong policy of no junk food allowed to be brought here, really encouraging the children to taste different vegetables and fruit, and then developing a menu that we knew we'd be hitting around at least 80% of their required daily dietary intake. So in case they go home, which many might, and don't have any food or don't have good nutritious food, that we know that they're going to have a good start in life. Families that are in need or so-called at risk, they'll be advised to come here so the children can eat well and the parents can work with me and with the other staff on simple things like we've got our recipes we've made up, so healthy eating practices. We have dental people come, we work with the children with their teeth, parenting programs on dental. We have an ear program, we check the kids' ears every day, we work with the clinic, close relation with the clinic.
If they're failure to thrive, then we get the strong women, ladies, to speak to the mothers, and we try and get them, we talk to them about bush medicines and bush tucker, and we also encourage them to attend the Janani Childcare Centre so that the children then get 3 meals a day, and the mothers also get taught how to cook down there as well. It's a real big help, because I don't know how else we'd do it without them. You know, because you can talk to them, but unless you show them what to do, we're not going to get anywhere, I don't think.
We usually have anywhere between 30 to 40 children in the morning of an average, and an average of around 5 to 6 mums that come and volunteer their time. They're seeing what we're doing. It vibrates out, so we've got all the staff. Well, the staff are eating healthy. They're seeing the healthy meals that are cooked here. They're learning through all the different workshops that we have. So they take that home to their families, and people have maybe up to 13, 14 people in their families at home, extended families, so that vibrates out. We have a lot of, different educational programs through the centre too, so, whether it's just singing in Tiwi, just overall pride in who they are. It's a big thing about making children feel proud of who they are. We can't meet the demand, and that's a sad thing. We turn up to 50 kids away in the afternoon, which is, it's really heart-wrenching.
Kids are hungry, it's terrible. And it's almost a survival of the fittest, because whoever's the oldest kid's going to get more than the youngest kid, because it's just the way it is.
When we first started looking at the nutrition program, how could children ever get anywhere if their housing conditions are poor? And that's probably our major issue here.
There are a lot of people living in condemned houses that pay rent and nothing gets done because the houses are condemned, so they're not going to fix them. And you get rat problems.
So that was one of the first letters went to the housing. And when you look at the malnutrition cycle, if they've got the germs, they've got a house which is, third world conditions, how can they ever, it doesn't matter how much healthy food they eat, can they ever get past where they're at? So first it was making sure we provided good food, then it was making sure they could actually get good food in the community, then it was actually educating the community on what good food is, and then now it's more of a focus on preventative, so teaching the younger generation how to cook good food, what good food is, and then just constant support for those mothers.
The programs that are really successful get in early and work with communities to set up good teams. They're really making a difference. Looking after the health of young children not only helps them now, but has tremendous benefits for the rest of their lives.
Yeah, all we can do is continue to keep on doing what we're doing and see these children grow up into healthy adults. Because at the moment we don't have a lot of healthy adults, but if I can get these kids to get them through their childhood with minimal diseases or chronic disease, then maybe they'll grow up into be nice, healthy, strong adults.
We tend to focus on those kids who are sick and not doing well. And when I go to a community, they're the kids that come in to see me. But if I go around the communities, there are a lot of families with kids who are doing really well. They're healthy, they're smart, they're growing up well.
In terms of the future for our children and the capacity for them to have a healthy beginning, achieve their potential, we have innumerable talented, committed, dedicated, trained people who are working towards improving child health for Aboriginal and Torres Strait Islander people. So I think that from that perspective, we have a bright future.